Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have an 8-month-old male who presents with eczema and poor weight gain. The patient was diagnosed with eczema at 4 months of age. He has been treated with numerous creams, but with little improvement. Mom states the eczema is getting worse on the face and also on the arms. Mom has noticed some hair loss over the past 2 to 3 months. Over the same time period, the patient has lost weight. She states the patient has 7 to 8 loose stools per day, but denies vomiting. The mom thinks he has not been eating like normal for the past several weeks. There are no significant past hospitalizations. His immunizations are up to date, and he has no known drug allergies. His birth history was normal, with a birth weight at the 75th percentile, 8 pounds and 1 ounce. Diet, he was breastfed until about 4 months of age, and he now takes formula, which is Celiac, and he also eats rice and oatmeal cereal and jarred baby foods. Developmentally, he crawls, he sits without support, and he vocalizes sounds. He lives with his mother and father, an 8-year-old sister, and a 5-year-old brother. The dad has asthma, and the sister has eczema. Physical exam reveals a temperature of 37.2, a heart rate of 102, a respiratory rate of 24, and a blood pressure of 88/54. Weight today is 5.8 kilograms, which is less than the 5th percentile, and his height is at the 50th percentile. In general, he is a cachectic appearing infant in no acute distress. On skin exam, you see severe eczematous changes on his face, and the face appears hypopigmented. There is alopecia of the frontal area of the scalp and eczema over his arms. HENT exam is normal. Lungs are clear to auscultation bilaterally. Cardiac is normal. Abdomen is normal. Back is normal. Genitalia is a normal male infant. Extremities, there is no clubbing, cyanosis, or edema. Full range of motion, but you do see some muscle wasting. And neural exam, there's no focal deficits, and he does appear to have good tone. This is his growth chart from his primary doctor's office. At birth, he was at the 75th percentile for weight. By 6 months of age, he had dropped to the 5th percentile for weight. By 7 months, he was less than the 5th percentile, and now at 8 months of age, he is well below the 5th percentile for weight. To summarize his problem list, we have an 8-month-old male who comes in with failure to thrive, eczema, alopecia, and diarrhea. So in this case, we have an 8-month-old child coming in with failure to thrive and eczema, along with some other symptoms like alopecia and diarrhea. So we're going to go ahead and create a differential diagnosis for failure to thrive for this child. When you think about failure to thrive, there's a lot of different causes of failure to thrive. And when you break down the different causes of failure to thrive, 75 to 90% are actually related to psychosocial reasons. So 75% to about 90% is related to psychosocial reasons, meaning that there is some issue with nutritional intake because there's lack of access to formula, or the parents aren't making the formula properly, or they are diluting it too much, or there's some malicious intent where they're neglectful or abusive and they're not feeding the child, so the child has poor caloric intake and poor nutritional intake. So those would be some of the reasons for the psychosocial causes of failure to thrive, and actually a majority of failure to thrive is related to some of these type of issues. And in only about 10 to 25% of the time is it actually related to some sort of organic cause. So in about 10 to 25% is there some organic cause of the failure to thrive. So in this patient, we're going to go ahead and talk about some of the organic causes of failure to thrive, and talk about how we would look those up or work those up while we have kind of ruled out the psychosocial causes by getting a good history, nutritional history, feeding history, psychosocial history, and looking for risk factors related to that. So now let's focus on the 10 to 25% that are organic causes of failure to thrive. And the biggest cause of failure to thrive when it comes to organic causes is going to be GI tract related causes. So let's talk about GI tract related causes of failure to thrive. So in this category, we have things like cystic fibrosis. So we know cystic fibrosis can cause you to have pancreatic insufficiency and diarrhea and poor weight gain and failure to thrive. So that's on the differential. Also on the differential will be things like celiac disease. So again, types of malabsorptive type of processes. In young infants who are formula fed, they can have a cow's milk protein intolerance. So they might have a milk protein intolerance and be kind of allergic to cow's milk and not able to tolerate it. And the severe form of that is called FPIES, is a severe form of milk protein intolerance where you have food protein induced enterocolitis syndrome. So FPIES, food protein induced enterocolitis syndrome, and cow's milk protein is one of the culprits for that. So that's something to consider as well. And then you can have other things that you just have, like bad reflux, where you're vomiting or spitting up most of your formula in your feed and not holding enough down to be able to gain any weight. Or you can have other anatomical issues that give you a lot of vomiting and things. So you could have something like a partial malrotation, so an anatomical issue in the GI tract that again is giving you a lot of vomiting, and you're not able to hold down enough formula to be able to absorb to get the calories that you need. Other things in this category, depending on the age, on some older kids, you might think about different type of like inflammatory bowel disease, like Crohn's disease, that can present with poor weight gain, usually in a little bit older child. And then also in a little bit older child, you might think about eosinophilic esophagitis or eosinophilic enteropathy. So eosinophilic esophagitis or enteropathy, where it's kind of basically bad food allergies and different allergens will cause you to have issues with absorption. So you can have inflammation with eosinophils in your esophagus and in your GI tract. And then there's other type of malabsorptive type of processes. So you can have a carbohydrate enzyme deficiency, so you can be born with that. So carbohydrate enzyme deficiency, and there's multiple forms of that, but basically you can't absorb different carbohydrates, and lactose intolerance is one of the things that we're commonly familiar with, which is not that common actually in kids, but there's other carbohydrate enzyme deficiencies that kids can have that can prevent you from absorbing food and getting nutrition that way. And then you can have other entities like a protein losing enteropathy. So a lot of times you can have a recent viral infection, gastroenteritis, and inflammation of the GI tract, and then you have malabsorption issues, and you have a protein losing enteropathy, and that can lead to failure to thrive as well. And then a few other things that are a little more rare include zinc deficiency. So zinc deficiency can give you failure to thrive and poor weight gain. And then something that we think about related to dermatitis, diarrhea, and dementia, right? In older adults, the 3Ds of a niacin or B3 deficiency, right? So a niacin deficiency, which again, we don't see that commonly in kids, But in older patients, you can have a niacin or B3 deficiency, where you can have the dermatitis, diarrhea, and dementia commonly associated with that. So these are some of the things you have to think about from a GI tract perspective, causing failure to thrive and poor weight gain in kids in the 10 to 25% that will have an organic cause. And then as we go on to the differential, there's other things that you would consider as well, other categories. So let's go on to other categories. Let's talk about cardiac causes. So cardiac causes of failure to thrive basically would be congestive heart failure, right? So if a child at this age, 8 months of age, had a VSD that started to have a lot of left to right shunting, developed pulmonary edema, and increased workup breathing, and they were burning more calories as a result of that heart failure. So that can definitely cause poor weight gain and failure to thrive. So CHF is a cardiac cause. So now let's go on to pulmonary causes. So pulmonary causes of failure to thrive. We already mentioned one, and that was cystic fibrosis, right? So that obviously causes a lot of respiratory issues with secretions and infections and things. So that can cause failure to thrive. Other things, if you have different things, different types of chronic lung disease, or if a child is premature and they have BPD or bronchopulmonary dysplasia, again, increased workup breathing, increased respiratory rate and respiratory effort, burning more calories, and that can cause failure to thrive and poor weight gain. Other things you can be having is like chronic aspiration. So chronic aspiration can do that. So if you have reflux or some neurologic issue, you can be aspirating. That can give you poor weight gain and failure to thrive. And if you have pneumonias and aspiration pneumonias, so that can do it. And then any type of chronic infection, so immunodeficiency, bronchiectasis, cystic fibrosis, like we mentioned. So anything that can give you pneumonias chronically, so immunodeficiency or other causes of pneumonia where you can have a TE fistula related to the aspiration or some other cause of having recurrent pneumonias, that can give you failure to thrive as well then. I mentioned neuro when I was talking about chronic aspiration, so if we talk about neural causes. So I mentioned the chronic aspiration, but that's usually if you have some sort of neurologic issue, right? So you have something like CP or cerebral palsy, where you have some sort of neurologic condition where you're not able to feed appropriately and you chronically aspirate because of the neurodevelopmental delay that some child might have. That can put them at risk for failure to thrive as well. Along with CP or other causes of neural issues, basically they'll have oral motor dysfunction. Right, so if you have oral motor dysfunction, so basically, you don't feed properly, you don't swallow properly, you might aspirate, you might have pooling of formula in your mouth, and you don't swallow properly. All of that could be neurologically caused, and you're not getting enough calories and nutrition, and can present with failure to thrive. Another category that we could talk about would include renal causes of failure to thrive. So a big thing here is renal tubular acidosis. So that's something you should always think about on a child coming in with poor weight gain and failure to thrive, to make sure they're not acidotic, and check their renal function to make sure they don't have renal tubular acidosis, because that can definitely cause you to have failure to thrive. And basically anything that can cause chronic renal insufficiency can also cause you to have failure to thrive as well. So similar to the RTA. So that's another consideration that you'd have to think about as far as causes of failure to thrive in the renal category. So the next category that we can talk about is endocrine. So let's put that here. So other endocrine causes of failure to thrive, as far as organic causes, can include thyroid issues, right? So you can have hypothyroid, or actually you can have hyperthyroid. Any of these can, either one of these can give you poor weight gain. So hypothyroid or hyperthyroid can cause you to have weight gain issues and poor weight gain. Other things can include a growth hormone deficiency. That can cause you to have failure to thrive and poor growth, or adrenal insufficiency. So that can also cause you to have poor growth and poor weight gain, so adrenal insufficiency, and then a couple other things under endocrine can include diabetes, so type 1, so diabetes mellitus, can definitely give you weight loss and poor weight gain and failure to thrive. Then the last category in this in endocrine we can consider it would be rickets or vitamin D deficiency. That would be another thing that we would consider. So rickets or vitamin D deficiency can actually give you failure to thrive and poor weight gain as well then. So I think these are some of the endocrine things that you have to think about as causes of failure to thrive. Okay, so now let's go on and talk about a couple other organ systems. As you can see, it's a very broad differential that includes almost every organ system. So now let's go to one organ or one category that really has to be considered. That would be infectious disease. So let's talk about ID. And we kind of started to talk about this already. So we mentioned the immunodeficiencies. So for sure, any immunodeficiency can give you failure to thrive. So the immunodeficiencies, we kind of alluded to some of them already, but obviously I think about HIV, so congenital or acquired forms of HIV, and then other immunodeficiencies can include common variable immunodeficiency and immunoglobulin deficiencies that can contribute to recurrent infections, pulmonary infections, and things that can give you poor weight gain and failure to thrive. Then another one to consider in this category would be Wiskott-Aldrich Syndrome. So Wiskott-Aldrich Syndrome is a common one that boards like to ask about. Wiskott-Aldrich. That's basically where you have IgM deficiency. So the IgM deficiency gives you a lot of otitis media and sinusitis and pulmonary infections, and you can get failure to thrive. And then the other big components of Wiskott-Aldrich, in addition to the IgM deficiency, is eczema and thrombocytopenia. So that's a common boards type of question that they like to ask about. So Wiskott-Aldrich syndrome, IgM deficiency, giving you failure to thrive and poor weight gain, along with thrombocytopenia and eczema. So that's something to consider as well then. So so these are some of the immunodeficiencies that you might start to think about, and there's others as well, but we'll kind of leave it at that. Other infections, other ID causes, infectious causes of poor weight gain, failure to thrive include TB. So TB can definitely give you a poor weight gain and failure to thrive. And then other infections like congenital infections, like torch infections. So newborns, neonates, they might be small for gestational age or have IUGR when they're born, so they might be kind of small. So you think about torch infections and congenital infections that might give you poor weight gain and things as well. And then if you have a child, like as in our case, you have somebody who has chronic diarrhea and things, and you think about different other infectious causes. So you might think about C. difficile causes of diarrhea, or ovine parasites like Giardia causing diarrhea and poor weight gain and failure to thrive. So parasitic infections you might think about as well then, and other ovine parasites potentially as well. So these are some of the infectious causes that you might think about for a child coming in with failure to thrive, either an active infection of some sort or an immunodeficiency leading to a secondary infection. In the last couple categories we've been kind of alluded to, so let's talk about genetic or metabolic type of things. So we've kind of talked about a few of these things, so genetic or metabolic causes of failure to thrive. So in this category, you can have a lot of chromosomal defects, so any chromosomal abnormality can cause you to have that, so a chromosomal defect, so any trisomy or other chromosomal defects that a lot of times will give you CP and neurologic issues, or you might have cardiac issues related to that, so a lot of the chromosomal defects you have to think about as well. And then the other inborn errors of metabolism, so you have the amino acid defects, organic acid defects, so any of those type of things, so any other what you call inborn error of metabolism, so amino acid defects, organic acid defects, any of those type of things can cause that as well. So I think these are some general things that you got to think about as part of your workup on a child coming in with failure to thrive. Then the last category that we'll talk about is going to be oncology or malignancy. So in this category, many malignancies will give you poor weight gain and failure to thrive because they have decreased appetite, they'll have fevers and fatigue. So a lot of malignancies can do that. And obviously the most common ones in kids include ALL and other forms of leukemia. That can give you poor weight gain, failure to thrive, and then neuroblastoma is always a consideration, and then Langerhans cell histiocytosis is another consideration as well. So these are some of the common oncology and malignancy considerations on a child coming in with failure to thrive. So as you can see, the differential for failure to thrive is quite extensive. And again, as I mentioned earlier on, most of the time, in fact 75 to 90% of the time, it's psychosocial, related to poor nutrition, inadequate caloric intake, and formula issues or feeding issues or abuse or neglect type of issues. And about 10 to 25% of the time is it an organic cause. And then when you think about organic causes, you think about a lot of different organ systems, with GI being a very large consideration, in addition to a lot of other areas that you have to think about as well. So with such a broad differential diagnosis, it's important to take a nice stepwise approach to the patient and the workup to determine what's happening. And the first thing you have to do is make sure it's nothing psychosocial by getting a good family history, a good feeding history, a good nutritional history, a good psychosocial history. And once you're sure it's not related to that, then you start to pursue some of the organic type of causes and the organic workup that you might consider. So let's go ahead and now talk about the workup that you would do on this type of a patient and the workup that we did on our patient. So for our 8-month-old patient, we approached it with a very open mind, and we recognized that the patient had failure to thrive, along with bad eczema, also alopecia and diarrhea. So we did a little bit of a workup, basic workup, got a CBC, a CMP, thyroid studies, a UA, and a celiac panel. And everything basically came back normal on that workup. So the CBC reassured us that overall he had good white cell count and didn't have the thrombocytopenia that you would see with Wiskott-Aldrich. His CMP was normal, so his electrolytes, his albumin, his LFTs, his kidney function was normal, his thyroid was normal, his urinalysis was normal, and his celiac panel was normal. So that helped us to rule out some of the things that we were initially thinking about on this patient. So then at that point, we kind of reassessed and reevaluated based on the symptoms, and we narrowed it down to a couple of things that he most likely could have and that we needed to look into. So when you have a patient coming in with severe eczema, refractory eczema, in addition to failure to thrive, there's maybe only 2 or 3 things that kind of jump higher on the list that you have to think about. So one, as we've been alluding to, is Wiskott-Aldrich Syndrome with the IgM deficiency, thrombocytopenia, and eczema. So we had done the CBC and his platelets were normal, so we didn't think he had Wiskott-Aldrich. That's one of the things to think about with failure to thrive and bad refractory eczema. The other one is Langerhans cell histiocytosis, where you can have histocytic infiltration into your bone marrow, into your skin, into your lungs, into various organs. And his CBC was totally normal, so that made that a little bit less likely. And then the other thing we were thinking about was this entity related to the GI tract, which was zinc deficiency. So we were thinking about a zinc deficiency in this child, given the fact that he had the failure to thrive, he had eczema, he had alopecia, and he had the difficult to control and refractory eczema and the diarrhea as well. So zinc deficiency became a little bit higher on our list. So we ended up sending a zinc level, and his zinc level actually came back very, very low, and that confirmed our diagnosis of zinc deficiency. Now, another term for zinc deficiency is another term is called acrodermatitis enteropathica. So acrodermatitis enteropathica. So that is a primary zinc deficiency. So you can have secondary zinc deficiencies as well, from malabsorptive type of issues and things like that. But you can have a primary zinc deficiency, and that would be acrodermatitis enteropathica, where basically you cannot absorb zinc through your GI tract. And because of that, you get a zinc deficiency, and that zinc deficiency then gives you acrodermatitis, so eczema or dermatitis and skin inflammation of the acral area, so your hands and your feet and your extremities, which he had. The enteropathica Eczema is more the diarrhea and a failure to thrive. So we thought he might have this acrodermatitis enteropathica, and we confirmed it by having a low zinc level. And interestingly, if you recall the history, he was breastfed for the first 4 months of his life, and he had no symptoms and didn't have any eczema and was gaining weight well. And then when he was transitioned to formula, that's when all the problems started. That's when he started to develop the eczema and the weight loss and things. And when you have acrodermatitis enteropathica, basically what happens is that there's a protein that we all have in our GI tract that helps for zinc transport and zinc absorption and zinc transport across the intestinal mucosa. And when you have primary zinc deficiency, you are lacking that protein that helps for transport and absorption. So breastfed babies, breast milk actually has that protein available in the breast milk. So while this infant was being breastfed, he was actually having some of the protein available to allow for zinc absorption. And then when he was switched from breastfeeding to formula feeding, then he no longer was getting the protein to help with the transport when he was off the breast milk, and that's when he started developing the symptoms. So breast milk can actually be protective because breast milk has the protein that is needed to allow for zinc absorption if you happen to be deficient in that protein inherently. So when he switched to formula, that's when he started having the trouble and not being able to absorb the zinc, and then developed the zinc deficiency. So we confirmed our diagnosis of the primary zinc deficiency, or acrodermatitis enteropathica, based on the low zinc levels. Basically, zinc is very important for infections and for growth and for wound healing and things. So you start to develop, when you have zinc deficiency, you start to develop some symptoms, signs and symptoms associated with that. And again, he developed these signs and symptoms after he was taken off the breast milk and was put onto to formula, and no longer was able to absorb the zinc because he was deficient in the protein, his own protein that would allow him to absorb the zinc. So basically, in zinc deficiency and acrodermatitis enteropathica, you can have alopecia, you can have the skin findings, the eczema, the dermatitis, you have poor weight gain and failure to thrive, you can have anorexia, you can have diarrhea, you can have a lot of super infections with like Candida in the skin changes area, and you can have delayed wound healing, so you can have a lot of issues with that. And he was actually manifesting some of these with the bad eczema, with the alopecia, with the poor weight gain, with the diarrhea. So he had many of these symptoms then. So the rash of acrodermatitis enteropathica, again, I mentioned it's over the acral area, so the extremities, the hands and the feet, but it also could be perioral, so around the lips, around the mouth. Then it also can be in the perineal area, so in the diaper area as well. You can see some of these changes in the dermatitis and the eczema-like findings. So, and most patients, when they have zinc deficiency and acrodermatitis enteropathica, almost all patients will have the dermatitis and the bad eczema, and almost all patients will have associated alopecia, and many will have diarrhea. So those are the three most common findings in acrodermatitis enteropathica then. And the treatment for this is basically giving oral zinc supplementation. And what happens is when you give oral zinc supplementation, you give enough oral zinc that you get some absorption of that oral zinc into the intestine and into the body, that you can overcome the zinc deficiency. So even though you are low in the protein, that helps transport it, but if you give enough zinc, then you can get some absorption even without that protein to be able to overcome a zinc deficiency. But if you don't give extra zinc and supplemental zinc, then the zinc that's just available in normal food products and formula and things like that is not enough. Not enough of it is absorbed, and that's why you get the zinc deficiency. So you need to give supplemental zinc and large amounts of zinc, knowing that only a small amount will be absorbed, but that small amount that is absorbed without the protein's help is enough to prevent zinc deficiency then. And basically, it's a lifelong type of illness, and they have to be on the zinc supplementation lifelong to prevent some of the complications associated with a zinc deficiency. So again, in this patient presenting mainly with failure to thrive, and also with eczema and alopecia and diarrhea, turned out to have primary zinc deficiency, and otherwise known as acrodermatitis enteropathica. So this is the differential diagnosis that you would consider in a failure to thrive patient, knowing that only 10 to 25% have organic causes, but it's a large differential, so you have to make sure that you are open-minded and approach it with all this in mind. So again, the CRASH case is meant to talk more about the analytical process and the thought process of thinking through a patient and the differential diagnosis. So I'm not going to go through a lot of these entities, so you can read more yourself on some of these entities. Again, the CRASH case is more to talk about the differential. So hopefully this was a helpful discussion on this CRASH case, and we look forward to seeing you at future CRASH cases as well.